Hello.
Hello, Dr. Lakshmi.
Hello,
Good
Dr. Mamta.
evening.
Good evening, ma'am.
Let's move on a second.
Good evening, everyone. We'll now be moving forward ahead with the next academic year of the Next Gen series. A very warm welcome to all the faculty and residents. Today we have the seventh session of the IPS Next Gen case presentation series, for which the presenter is Dr. Soumya Bhatt, finally a resident from AIMS Jodhpur, and the topic is of a left-sided abdominal mass. The examiner for today's session are Dr. Professor Dr. Lakshmi Sundarajan, ma'am, HOD of KKCT at Chennai, and Professor Dr. Mamta Sengh, HOD of CNBC Delhi. Both examiners are accomplished pediatric surgeons and an inspiration to all us young trainees. So without taking further time, let me hand over the screen to Dr. Soumya to begin her case presentation.
Good evening, ma'am. Ma'am, is the screen visible?
Yes, it is visible.
Okay. Good evening, all. Today we'll be discussing the case of a 4-year-old male child. He's a resident of Sumerpur, Rajasthan, and the informant was the mother, who seemed to be reliable. The child presented to us with the chief complaint of lump on the left side of the abdomen, which was incidentally noted by the mother 1 month back. With the above mentioned complaints, after 10 days of noticing the lump, the child was taken to a local practitioner, evaluated there, and then referred to our center for further management. Currently, since the first presentation, the parents have noted that there's a progressive increase in the size of the lump located in the left upper abdomen. Almost a 3-fold increase in size has been noted over the duration of the past 1 month, from the size of a cricket ball to approximately its current size. Can I proceed?
Yeah.
There's no history of any pain abdomen, fever, no history of any documented weight loss, no history of any sort of abdominal trauma, no history of difficulty in passage of urine, blood in urine, pain or crying during micturition or pus in urine, no history of any pain or vomiting, no history of any altered bowel habits, no history of any breathlessness or fatigue, no history of any skin changes, no history of easy bruisability, no history of bulging of eyes, abnormal eye movements, or any periorbital ecchymosis, no history of difficulty in walking or pain in the limbs, no history of any asymmetric limb growth noted by the parents, and no history of any watery diarrhea, flushing, or excessive irritability noted in the child. Moving towards the past history, there is no significant past history, and the child has never had similar complaints in the past. The antenatal and the birth history were also not significant. The child was a full-term institutional born, normal vaginal delivery born child. No issue of any NICU admission at the same time. The bowel bladder habits are preserved. The appetite is good. And in family history, the child is born out of a non-consanguineous marriage. There's no history of malignancy or any similar complaints in the family. And the child is developed, the development is as per the age. Shall I proceed with the examination, ma'am?
What is your clinical impression with this history?
Ma'am, we have a 4-year-old male child with an incidental noticing of the lump abdomen by the mother. Considering the age of the child and the rapid increase in the size noted by the parents over the duration of 1 month, I'm more towards a neoplastic etiology. Considering the left side of the origin being in the left upper abdomen, the organ of origin could be either a renal origin or a splenic origin, or it could be from the colon, or it could be a retroperitoneal origin, or it could be a retroperitoneal as an adrenal, or otherwise retroperitoneal in origin. So it could either be coming towards the renal pathologies, it could be lesions such as Wilms tumor, followed by other non-Wilms renal tumors, which would be seen in this age. Apart from that, it could also be neuroblastoma in the retroperitoneal group. And coming to the congenital spectrum of the possibilities, it could be a hydronephrosis, which was incidentally noted by the parents, or it could also be other etiologies such as a mental cyst or a colonic duplication cyst or a mesenteric cyst, which has been noted by the parents now.
So would you be interested in knowing the occupations of the parents if you are thinking of malignancy?
Ma'am, exposure to organophosphates and chemicals is known to lead to tendency of malignancies in the exposure would lead to chances of malignancy being more common in the offsprings. So that should have been taken.
Okay, good. So
We'll proceed with the
proceed with the examination part.
The child was examined after consent, lying on the mother's lying on the bed. The child is conscious, appears moderately built and well looking. The height and weight are between 50th and 75th centile for his age. The vital parameters are normal, and the BP is also between the 50th and 90th centile for his age. In routine examination, the significant finding of pallor was present. Interest, cyanosis, edema, and lymphadenopathy were absent. Coming to head-to-toe examination, there is no evidence of any macro or microcephaly. The hairs are evenly pigmented. There is no evidence of any lesions such as nodules, hyperpigmented areas, bruisings noted on the skin. No evidence of any syndromic facies. In the eyes, there is no evidence of aniridia, any pigmented irises. The ears are normal. There is no evidence of any macroglossia or any gingival bleeds. Also, there is the spine appears to be grossly normal. No limb hypertrophy or asymmetrical limb enlargement is noted. No evidence of any uric hypospadias. Coming to the abdominal examination inspection, the child, the abdomen is asymmetrically distended, more on the left side than the right side, with visible mass involving the left lumbar, the left hypochondriac, umbilical, and the epigastric regions. The umbilicus is centrally placed. There is no evidence of any dilated veins or any visible bowel loops or peristalsis. The left renal angle fullness is noted. Genitalia seems to be normal male type, with left hemiscrotum slightly enlarged compared to the right side. No other visible swelling was noted. The anal opening was normally located, and spine appears grossly normal. On palpation, the inspectory findings were confirmed. There is no local rise in temperature and no tenderness. On palpation, of 18 cross 15 centimeter lump was noted, occupying the left hypochondrium, epigastric flank, left flank, and the umbilical regions. The lump is extending from the posterior axillary line on the left side to just proximal to the right mid clavicular line, and craniocaudally it is extending from just 2 centimeters below the costal margin till around 5 centimeters below the umbilicus along the left costal margin. The surface of the lump is smooth. The margins are well defined. The lump is firm in consistency. I am able to insinuate my fingers between the lump and the costal margin, and the lump does not seem to move with respiration. The skin over the lump is pinchable, and the lump is bimanually palpable. Normal male genitalia is noted. Meatus is normal in location, with bilateral testis palpable within bilateral hemiscrotum. Feel of bag of worms is felt in the left hemiscrotum with visible dilated veins, suggestive of left varicocele. No other palpable masses, swellings, or organomegaly could be appreciated. On percussion, a colonic band of resonance was present over the lump. The rest of the lump was dull to percuss. Tympanic was noted over the rest of the areas. No evidence of any shifting dullness of fluid thrill could be appreciated. On auscultation, vowel sounds were heard in normal intensity and frequency. No bruit could be appreciated over the lump. Rest of the system examination was normal.
Okay. So what is your impression?
Ma'am, since on examination, we have a lump occupying the left flank, the left hypochondriac, slightly involving.
Actually, could you just summarize your findings? Summarize it before you carry on.
Yes, ma'am. A 4-year-old male child with incidentally diagnosed lump on the left side of the abdomen, primarily involving the left flank region and extending to the epigastric, hypochondriac, and the umbilical regions, with no other significant complaints, with rapid increase in size noted by the parents over the duration of 1 month, and with presence of anemia. These were the only positive findings.
So you're on examination?
Ma'am, on examination, the lump is smooth on palpation. The margins are well defined. I'm able to insinuate my finger between the lump and the costal margin, and the lump does not seem to move with respiration. There is a colonic band of resonance which can be appreciated over the lump. Therefore, I'm inclining towards a renal lump.
You've said about, I mean, such a large lump. It's already palpable from everywhere, isn't it? Anterior abdominal wall, posteriorly. And I think you've said it's bimanually palpable. I mean, when it is already palpable from all sides, don't know whether you have to say that, isn't it? And certainly there's no question of palatable because it's such a large lump. So you said you think it's a renal lump, but why would you say it's a renal lump? Why not something else?
Ma'am, primarily because one, the lump is occupying the flank, is arising from the flank region. I'm able to
Yeah.
insinuate my finger between the lump and the costal margin on the left side. I can appreciate the colonic band of resonance. The lump does not move with respiration. So all these findings would be suggestive of a renal lump. And
Well, it's
renal aneurysm is also there.
crossing the midline.
Yes, just crossing the midline as well.
So what else can be the DD? I mean, other than renal lump, can it be something else from your clinical examination?
Ma'am, presence of colonic band of resonance and the fact that I'm able to insinuate my finger between the lump and the
So
costal
there is no
margin.
DD at all. You don't want to offer anything other than renal lump as your differential diagnosis.
Ma'am, organ of origin would be renal, but apart from that, if before palpation, I was
There's
thinking
something else which is suggestive very strongly that it's a renal origin.
Mm,
One more finding that you've got is very suggestive of a renal origin for this lump. The presence of varicocele on the left side. Right.
yes, very good.
So that is also very strongly suggestive that this is going to be a renal lump rather than. So, yeah, carry on.
So I'll proceed with the the investigations, ma'am, now.
Yeah, okay.
Okay. This child was referred to us, and an ultrasound was already done at the time of referral. The ultrasound done outside was suggestive of a 16 cross 10 centimeter solid mass noted in the retroperitoneal space, causing displacement of the bowel loops. Left kidney was not appreciated separately. The rest of the ultrasound findings were normal, and they had said that the impression was of a query wins versus a neuroblastoma.
So, okay.
At the same time, I would like to do hematological
So it's a
investigations.
solid mass, like it's not variegated mass, it's a solid mass. There's no cystic spaces, there's no necrotic areas, nothing. They've said in ultrasound it's a isoechoic solid mass, is it?
Ma'am, they had actually they had not mentioned isoechoic per se. They had just mentioned solid mass. It was done outside, so it was not a very accurate.
Okay. Okay.
So since this ultrasound was done outside, would you like to repeat it at your own center and to look for the other findings which are not mentioned here in the ultrasound?
Yes, ma'am. The ultrasound is not given us the details which we would be ideally looking for. So we could have repeated the ultrasound, but in this case we chose to repeat the CT. We have just done a CT directly. Ideally, if we could have repeated an ultrasound so that other details could have been provided which are missing in this ultrasound, such as they have given us the size and the nature of the mass, but the exact organ of origin, the exact extent of the lesion, the status of the vascularity, that is any thrombus with Doppler, if they could appreciate any thrombus, any presence of ascites, any lymphadenopathy which they could see, the status of the contralateral kidney, those details were also required.
Right. So
Is there any calcification that is reported on this ultrasound?
No one. They've not mentioned any
No
calcification.
calcification. Okay. Will that help you to decide what will be the histology?
Ma'am,
Depending on the
calcifications.
test?
Yes, ma'am. Calcifications are more common in Wilms tumors compared to, are less common in Wilms tumors compared to neuroblastomas. In neuroblastomas, we'll have coarse calcifications, and in Wilms tumors, we'll have axial calcifications, but they will be better appreciated on a CT if they have not mentioned on ultrasound. Though they can obviously it on ultrasound as well, but better on CT.
Okay. Okay, yeah.
So we also proceeded with hematological investigations at the time of admission. There was anemia, and rest of the renal function and the INR and electrolytes, etc., were within the normal limits for this child.
So what is the
Okay.
cause of this patient was not having anorexia. There was no fever. What was the cause? What could be the cause of low hemoglobin?
Ma'am, usually in patients with tumors, the cause of anemia would likely be hemorrhage or bleeding. But in this particular patient, it was not there. Apart from that, nutritional causes can still be there.
Sorry, I didn't get you. What will be the cause? Nutritional
Ma'am,
cause
usually
is
should
not
be
there. So what do you think is the cause?
nutritional causes could be there, and hemorrhage in the tumor could also lead to anemia.
Mm. Okay.
Tumor rupture. So we proceeded with the.
That is the reason for this rapid growth, or the rapid growth is just a tumor that's growing so fast? Because they said it has grown from a cricket ball size up to crossing the midline.
Yes, ma'am. Ma'am, since the growth is rapid, therefore I'm more inclined towards a neoplastic etiology. However, benign lesions or benign masses such as a tense hydronephrosis could also present with the increase in size after trauma or trivial trauma, which could lead to infection and increase in size, which could have been noted.
Okay. Yeah.
So after this, we proceeded with the cross-sectional imaging. We have done a thing is yeah. So we've proceeded with the cross-sectional imaging, which would be a CT, contrast enhanced CT abdomen along with thorax. In the CT, we can see a large heterogeneous lesion in the left side of the abdomen, which is clearly crossing the midline. We can appreciate the contralateral kidney. And we can there is not much evidence of calcification, and we can see these hypoattenuated regions, which could be suggestive of necrosis. Apart from that, regarding the vessels, actually those images, I'll just load one
In
second.
what image do you have to look for calcification on a CT?
Ma'am, non-contrast images. So I was
You're looking at contrast pictures here.
yes,
So
on
it's
the
a non-contrast you have to look for calcification. Okay.
yes, actually I loaded it. Got one more.
Okay.
So what
Take
type
your
of
time. It's all
contralateral-
right.
This is not opening.
I think it'll just take some time. Got to give it time.
Yeah. Since we've done the CT thorax, so looking at the lung window, we are not. I'm not able to appreciate any evidence of any metastasis in the thorax. And this is the venous section of the CT. So here we can appreciate the aorta and the IVC here. This is the large heterogeneous lesion. with hypoattenuated areas. I'm not able to appreciate the renal vein. It seems to be likely compressed by the gross lesion, the large lesion.
Is CT a good method of looking at renal vein?
Ma'am, I would trace the IVC and see the follow from the kidney, the insertion of the renal vein.
Is CT a good method to assess for renal vein thrombosis? Simple
Yes,
question.
ma'am, ultrasound would be a better modality for assessment of the vessels.
So both MRI as well as an ultrasound, Doppler ultrasound are better modalities to look for renal vein thrombosis than CT. Okay. Yes. So
Why
what information do you need from the CT? Okay, we can see this big mass. So what else do we want to know?
And from the cross-sectional imaging, we would like to confirm the findings of the ultrasound, which is a subjective parameter. It's a more objective criteria. So the exact size of the lesion, the location of the lesion, those findings will confirm. Apart from that, we'll look at the relationship of the lesion with the adjacent structures, the resectability of the lesion, status of the contralateral kidney, and if any metastasis, evident metastasis, any enlarged lymph nodes, which we can appreciate. Those we'll be looking. And of course, thrombus also we'll see, but
You missed
So
out
all
other
these points
important
are,
things.
and
yeah,
my
all these
metastasis to the chest.
points are better appreciated in MRI. So why did you choose CT over the MRI? You are
Ma'am,
facilitating both the investigations available in your institute.
yes, ma'am. Those facilities are available, ma'am, but due to logistic issues, it's easier or it's faster to get CT, firstly. Secondly, MR would require sedation and anesthesia for the baby. Therefore, we chose to get the contrast CT done, ma'am. Though definitely these things could be better appreciated on MRI.
So essentially on the CT, you want to look at this mass and the relationship to the left kidney. So is there any normal kidney left? Is there a compressed kidney left, or is it involving the whole kidney? Are
Yes,
there
ma'am.
any lesions in the other kidney? So is it a bilateral lesion or a unilateral lesion? Okay, that is number 2. Number 3, are there any visible nodes in the retroperitoneum? Is there any metastasis to the liver? You said the hemoglobin has dropped. So you were suspecting there could be a bleeding either into the mass or there could be any rupture. So in which case you will be looking for free fluid in the abdomen. Right.
Ma'am, if there is rupture of the tumor, then we'll be looking at looking for free fluid in the pouch of Douglas and the pelvis.
So also whether it is in is there any infiltration into the diaphragm? So that's another thing where it is it breaching the capsule on your CECT? Is there any infiltration into the diaphragm? So those kind of questions. So rather than just saying vaguely, I'll be looking for this and that. Specifically, what are the things you're looking for? I mean, you're looking in the chest for metastasis. Okay. So you can be very precise because then it means that you know where this tumor is going to go, where it is going to metastasize. Okay.
Yes.
And then if you are not sure whether it is a renal mass or whether it is a neuroblastoma, then you want to see its relationship to the vessels. So what will be the relationship of a renal mass and a neuroblastoma? How will you differentiate based on relationship to the great vessels?
Ma'am, a Wilms tumor or a renal mass would push the great vessels rather than a neuroblastoma, which would encase the vessels.
Okay. Yeah. Okay. Okay. So what do you think it is based on this? And have you done any other investigations?
No, ma'am, we've just done the blood workup and the cross-sectional imaging. Also, on the imaging, ma'am, there was one lytic lesion which is noted in the vertebral body. Here. So it is just a query metastasis to the bone as well. So they have reported. with regarding the presence of lytic lesions in the L5 vertebra and the acetabulum. So now we have proceeded for this child with a biopsy for diagnosis. Tissue biopsy that is awaited.
How did you do the biopsy?
Ma'am, because the imaging findings are not characteristic of a Wilms tumor, and presence of the lytic lesions could be suggestive of metastasis, bony metastasis. So the diagnosis of it being a non-Wilms renal tumor, such as a clear cell sarcoma, is a possibility. So to rule that out, we've done a biopsy, which is awaited at present.
How did you do the biopsy?
Ma'am, the biopsy was an ultrasound guided procedure, which is done under ultrasound guided, and a core needle biopsy was done.
Okay. And you're waiting for those results, is it? You haven't got the results yet.
Yes.
Yeah. Suppose you had a lesion in the other kidney on this. So let us assume you didn't have this metastasis in the bone, right? So what will this be? What will be your DD based on this?
Ma'am, presence of another lesion in the contralateral kidney.
First, without just talk about you got this so far, you didn't have the bony metastasis. Without the bony metastasis, so what would you think this is?
Ma'am, I would likely think it is a bilateral Wilms tumor. So
No, I'm not talking about the other side. Just don't assume anything with the other kidney.
only this.
You have your exact findings, only you don't have the bony metastasis, right?
Yes.
Okay.
So considering the age of the child being 4 years old and it being a renal lump, with these characteristic findings, I would think it is a Wilms, most likely to be a Wilms tumor. Considering the cross-sectional imaging findings and the massive size of the tumor crossing the midline, I would think of starting chemotherapy for this child rather than considering an upfront resection.
So do you do upfront resection for Wilms tumors?
Ma'am, we usually at our center we follow the COG protocol. So we do upfront resections, but in cases with such large lesions where the chances of tumor spill and staging the tumor to stage 3 would be high, in those cases we do not opt for upfront resection.
So is there something else? I mean, is there some way you want to know what's happening with the renal vein and the IVC? What imaging do you need to know?
Yes, we need to see whether there is IVC thrombus and the exact extent of the renal vein and the IVC thrombus. If the thrombus is infrahepatic or hepatic, then we can consider still consider surgical resection if the size of the lesion is smaller. But if it is a suprahepatic IVC thrombus, then in those cases less likely to we won't be considering upfront resection. So to consider whether we'll go for an upfront section and the tumor is resectable or not, we do need to see the status of the thrombus if present.
So now we go to the next step. Suppose there was a lesion in the other kidney. So without a lesion in the other kidney, what stage do you think this tumor is going to be if it is a Wilms?
Sorry, ma'am, the connection severed.
With this present, again, ignore the metastasis in the bone. So you've got this big lump here. Okay, and you've got your CT findings and imaging. Based on this, what stage do you think this tumor is likely to be?
Ma'am, considering it's a surgical pathological staging for Wilms tumor. So the exact staging I'll be able to do after the resection only. But I can after there's no lymphadenopathy, there is no thrombus.
If there is a lesion on the other side, then
Bilateral
what
lesion.
stage? If there is a bilateral lesion, then what does that become?
It will be stage 5, and we'll have to do individual staging for both kidneys.
Okay. So tell me about the staging for Wilms.
Ma'am, COG classifies Wilms tumors into 5 stages. Stage 1 would be a localized tumor to the kidney, not breaching the capsule, not involving the renal sinus vessels, and it is completely resected with no residue. That would be a stage 1 tumor. Stage 2 tumor would again be a tumor which has penetrated the capsule and has involved the renal sinus vessels, but we are able to completely resect it. So it still becomes a stage, so it's a stage 2 tumor. In a stage 3 tumor, we would either have a gross
and tumor thrombus.
Presence of tumor thrombus will make it a stage 3 tumor. So in stage 3, a tumor which is unresectable according to the findings, that is presence of any IVC thrombus, if there is any tumor spill or any tumor rupture, and those findings will make it a stage 3 tumor. And
presence
stage
of lymph nodes.
Yes, and presence of lymph nodes, abdominal lymph nodes, involvement of abdominal lymph nodes would also make it a stage 3 tumor as per COG. And stage 4 would be again hematogenous spread, distant mets, and stage 5 would be a bilateral tumor.
Okay.
What is the difference between the tumor spill and the tumor rupture?
Ma'am, tumor rupture is the accidental breach of the capsule which happens preoperatively, and tumor spill would be the rupture, the breach which happens intraoperatively.
So since this patient is having a light lesion in the vertebra, would you like to add some investigation for your workup, to complete your workup?
Yes, ma'am. Since we are considering the possibility of it being a clear cell sarcoma, and we can see the presence of lytic lesions in the bones, so a bone scan should also be done for this patient.
And would you like to rule out metastasis in the brain also?
Ma'am, brain metastasis, the lesions which are of rhabdoid etiology are more likely to metastasize to the brain, and a clear cell sarcoma would more likely metastasize to the bone. So I would, if considering clear cell sarcoma, I would wait. But since we are waiting the biopsy if I was suspecting a malignant rhabdoid tumor of kidney, then I would get the brain imaging as well.
So now you have done a biopsy, no?
Ma'am, biopsy is awaited at present. We have done it.
So how long would you wait for giving chemotherapy to this patient? If the biopsy is supposed taking 15 days for its complete report, because for a core tissue, you may need a immunohistochemical analysis also. So would
Yes,
you
ma'am.
wait for giving chemotherapy because tumor is so long, so large?
No, ma'am. We would start with the DD4A regimen for this patient while awaiting for the biopsy. If we cannot get the biopsy within a week, we usually tend to start with the chemotherapy, and then according to the biopsy report, we can change it.
So,
Right. Okay. Is this likely to be a clear cell sarcoma, you think? What are the points in favor of it being a clear cell sarcoma?
Ma'am, the fact that there is a rapid increase in the tumor size with crossing of the midline with the lytic lesions. So these points favor towards a clear
Also, the
cell
tumor is not having the typical variegated appearance
of
on
a bill.
CT, like a Wilms, right?
Yes.
Right. Okay. You
what
were
is the
telling us. Yeah, go on.
Suppose this tumor responds to your DD4A regime, and your biopsy is favoring the Wilms tumor, then what will be your further plan of management?
Ma'am, once we start chemotherapy, we'll reassess at 6 weeks and consider the resectability at that time through a repeat cross-sectional imaging. And if the tumor is resectable at that time and the tumor responds, so we can consider for left-sided nephrectomy.
Can you tell us about the associated genetic conditions for renal tumors?
Sorry, ma'am. Genetic
Genetic
conditions.
conditions associated with brain tumor.
Okay, so usually they are WT1 and T2 lesions. This would include Dennis-Drash syndrome. It could include Wagner syndrome in the WT1 mutations, and in WT2 it would include Beckwith-Wiedemann and this Frazier syndrome, and also other syndromes like Perlman and P53 mutations are also there, and familial and Fanconi's anemia associated with tumors. Those are also there.
So aniridia comes in which syndrome?
Ma'am, it comes in Wagner, which is a WT1 mutation of 11p13. So in that we have Wilms tumor, aniridia, genital abnormalities, and intellectual impairment.
And components of Beckwith-Wiedemann?
Ma'am, Beckwith-Wiedemann will have it belongs to the overgrowth pool. So in that we'll have hemihypertrophy, we'll have omphalocele, we will have hyperinsulinic hypoglycemia, we'll have macroglossia, and again Wilms tumor, and tendency for other tumors such as hepatoblastoma will also be there.
Well, good. Good.
So now you have done nephrectomy. Can you elaborate the steps of nephrectomy in this patient?
Yes, ma'am. For a left-sided nephrectomy, I'll make a left transverse incision, generous incision, so that since the tumor size is big, so I'll make a generous incision sufficient enough for the tumor to be delivered easily without any spill. Once we have entered the abdominal cavity, we can take two approaches, either the hilum first approach or the pedicle first approach, or the or mobilize the tumor first. Considering the size of the tumor, I would like to do the mobilize the tumor after taking down the colon. I would like to mobilize the tumor peripherally and then go towards the hilum. First, we'll take down the ureter, clip the ureter as close as to the bladder. Identify the hilum by tracing the ureter up. At the hilum, we will see the order of renal vein followed by renal artery, but we have to delineate and ligate the renal artery first, followed by the renal vein.
Which will be anterior?
Sorry, ma'am.
Which will be first? Which will come first?
Ma'am, we'll visualize the vein first, but we'll ligate the artery first.
I'm a little confused. You said because it is a large tumor, you want to mobilize the tumor first? You want to go to the...
Rather than doing a pedicle first approach, it will be difficult for us to access the pedicle or the renal hilum first. So in attempts to do that, doing that, we might injure
The large tumor, you think you'll be able to mobilize all or not?
Ma'am, I think we'll be able to, after chemotherapy, we might be able to deliver
After chemotherapy. Okay.
After chemotherapy, we might be able to deliver it. And also, when we had entered the peritoneal cavity, at that time, I forgot to mention that we have to look at the presence of any metastasis in the liver and any peritoneal metastasis, evident peritoneal metastasis, if we were able to appreciate.
Is it necessary for you to check the other kidney?
Ma'am, not anymore, because the cross-sectional imaging is pretty sensitive. So if on the CT we do not have any doubt of a lesion in the contralateral kidney, then we don't have to check it.
Is there any indication for doing cystoscopies in such patients, in patients with Wilms tumor, before proceeding?
Yes, ma'am. Lesions which had patients who had presented with hematuria, in those cases we should ideally do a cystoscopy before proceeding in order to see the extent of the tumor, whether it is invading the bladder. And if it is invading the bladder, that then at the time of resection we have to be careful not to transect the tumor at the time of clipping the ureter. So we'll for that we need to do a cystoscopy beforehand.
What is the cause of varicocele in this patient?
Ma'am, due to the size of the lesion, it is likely compressing the renal vein, as we could not appreciate on the CT as well. And the gonadal vein would be draining into the renal vein on the left side. So that would lead to...
Compression on it is causing the varicocele.
Sorry, ma'am, compression on the
This
renal vein.
compression is causing the varicocele, you're saying?
Is some compression on the renal vein, which prevents the gonadal vein from into draining.
Is it not more likely that there is a tumor thrombus which is obstructing?
That could also be the case, ma'am. But
A lot of patients with, I mean, we've seen a significant number of patients with Wilms. How many of them have got a varicocele?
Probably the second case I've seen. I've not
That's what I'm
encountered.
saying. So most of them don't have a
Don't have a
varicocele.
varicocele.
So when you see a varicocele, you have to start, you've got to think. Because in all the patients, the Wilms tumor is large, it's compressing on the gonadal vessels. It's not causing a varicocele. When you see the varicocele, you've got to ask yourself, is there a renal vein thrombus that is causing obstruction,
The
okay,
right.
to
Yes.
the gonadal vessels? All right. I think she was asking for steps of surgery, and we finished the steps of surgery. So you said you're going to go to mobilize the kidney and then go to the hilum.
Yes, ma'am. We have to mobilize the colon, reflect the colon, identify the Gerota's fascia, enter the Gerota's fascia, and then proceed with the mobilization of the kidney or the lung, and then access the hilum, ligate the artery, followed by the vein. And to access the hilum, we had to trace it. We usually identify the ureter and trace the hilum.
Then, after that,
Would you do dissection outside the Zerota's fascia or inside the Zerota's fascia? Zerota's.
Ma'am, we do radical nephrectomy. So ideally, that would encompassate a removal of the gerotas as well, along with the kidney and the perineal fat and the adrenal. But adrenalectomy is no longer recommended until unless it's an upper pole tumor now. So what we practice traditionally is a radical nephrectomy.
no, but this is involving the whole kidney now. It's involving the upper pole also.
For this, yes, ma'am, for this adrenal has to be removed because we
So
cannot.
you have ligated the vessels in the hilum. Then what? What are you going to do after that?
Ma'am, after ligating the renal artery followed by the renal vein,
Yes.
then we continue with our mobilization, and we divide the ureter, and then we can resect the.
So let's say it's not a clear cell sarcoma. Let's say it's a Wilms tumor. Or if you want clear cell sarcoma, it doesn't matter. What else do you have to do? So you then take out the tumor. Yeah.
Okay, so
Then
we deliver the tumor, take it out, and then place titanium clips for radiotherapy. If
where will you place the titanium clips?
Ma'am, on the lower border of the tumor and the lateral extent, because medial extent will be the spine itself.
So lower border of the tumor bed.
Tumor bed, sorry.
Okay, but you have to actually mark it up to where, because the tumor bed will be smaller, the tumor is bigger, right? So where the extent of the tumor was. Do you understand?
Yes, ma'am.
So the tumor bed, when you're dissecting, so you've gone down from below the tumor and then you're lifting it up, and then your tumor bed is going to be further down. So you've got to mark your clips up to where the tumor would have been. Okay, so that you are covering all of that area for radiotherapy and laterally.
Yes.
What is the danger in renal tumors that are crossing the midline? Surgically, such large tumors, what is the danger when they are crossing the midline?
When they're crossing the midline, there is a chance that we'll injure the major vessels such as the SMA if it is on the it's a right-sided tumor coming towards left, or we would injure the IVC while doing the mobilization. That would be.
Sorry, I couldn't hear you properly. Just say that again.
Ma'am, if the lesion is big enough to extend contralaterally, there is a chance that we'll be injuring the we'll be injuring the major vessels such as SMA or the branches of IVC, or also injure the opposite hilum if we are not careful.
The big danger is actually injuring the vessel going to the opposite kidney. Okay, so that's important for us to note. So, okay, so you've done this, you've placed your titanium clips, then what else?
Then, ma'am, I have to do lymph node sampling. So for proper staging of the lesion. So for lymph node sampling, ideally we have to take lymph nodes from at least from at least 7 stations. This would include hilar, suprahilar, and infrahilar, para-aortic and paracaval, interaortocaval, and iliac.
See, this is a left-sided tumor.
For this
So
lesion, ma'am.
what?
Sorry, ma'am. For this lesion, we'll be taking suprahilar and hilar and infrahilar para-aortic lymph nodes and interaortocaval lymph nodes and iliac lymph nodes and mesenteric lymph nodes.
Suppose the lymph nodes are not enlarged, then also you will do all these lymph node sampling.
Yes, but because gross examination might or a ballpark figure which we see on the during the intraoperative evaluation might be wrong. So it is better to sample the lymph nodes for so that we have accurate staging and we don't downstage the tumor.
Right.
Tell us something about renal vein thrombus. How are you going to tackle that for surgery?
For
How are
renal
you going to tackle renal vein thrombus?
For a renal vein thrombus, once we know that there is a renal vein thrombus on the imaging, at the time of the surgery, we have to palpate the thrombus within the lumen, identify it, and try if it is not infiltrating the wall of the vessel, then it is most likely to come with the lesion itself once we remove the tumor. And if it is involving or if it's infiltrating the walls, in that case, we have to see the extent of involvement. If there is a IVC involvement, then we might have to do a chivotomy and remove the tumor thrombus. And if the thrombus extends to supra hepatic IVC level, then at that time we might require cardiopulmonary bypass and then consider excision for chivectomy, excision, and then grafting to reconstruct the vessels. So that has to be decided preoperatively.
Have you seen a thrombus extending into the heart? Have you seen any thrombus that is requiring cardiopulmonary bypass?
Ma'am, one patient had presented to us, but the child did not survive the chemotherapy itself. So that one case I've seen.
Most of the time when patient comes to you with a large thrombus, by the time you give them chemotherapy, a lot of that thrombus shrinks. So the need for the cardiopulmonary bypass and all has come down dramatically because of using chemotherapy preoperative sessions. Okay.
What is the umbrella protocol for now? You will send this nephrectomy specimen for histopathological examination. What
Yes,
is the
sorry, the voice got cut.
Now, since you have done a radical nephrectomy, and now this specimen will be sent for histopathological examination.
Yes,
So
ma'am.
what is the umbrella protocol used for assessment now for these patients? The patients where pre-operatively chemotherapy has been given.
Yes, ma'am. For these patients, if preoperative chemotherapy was given, so according to the SIOP umbrella protocol guidelines, we will see see whether it's a completely necrotic lesion, whether it is a which type of blastomal predominant, epithelial predominant, or stroma predominant thing is there. So we have to see the tumor viability, how much of the tumor is viable. If less than 1% of the tumor is viable, we'll say it's a completely necrotic lesion. If the tumor viability is more than 33%, out of that 33%, we have to consider which kind of lesion is more, out of the 33%, which cell is more predominant. That is, if it has to be an epithelial kind of lesion, that would have a tumor viability of more than 33%. And out of that 33%, the 2/3 of the lesion would belong to that particular kind of cell, like epithelial would be would be 66% or more, and the blastomal component has to be less than 10% in this situation. So we could have epithelial, we could have stromal, we could have a mixed kind, and all these will fall into the intermediate category. And a blastomal, presence of anaplasia, and other non-renal, other non-WIMS renal tumors such as anaplastic or clear cell sarcoma or malignant rhabdoid tumor kidneys, those will be towards the high risk category.
How do you identify anaplasia in this histological sampling? I mean, the slides.
Yes, anaplasia can be of two kinds. It could either be a focal anaplasia or it could be a diffuse anaplasia. In focal anaplasia, we would see discrete areas of anaplasia within the slide. A single discrete lesion would be there. In a diffuse anaplasia, we could either see multiple areas of anaplasia within the same slide, or it could be extrarenal. That is, there could be anaplasia which is extending beyond the kidney, presence of anaplasia beyond the kidney, or presence of anaplasia in a random biopsy sample could be there, or there could be presence of focal anaplasia with severe nuclear unrest at another location in the slide. So these would be considered as diffuse anaplasia. And to see anaplasia per se, we would see presence of mitotic figures if there are there, increase in the NC ratio with the nucleus being approximately 3 times the size of the adjacent normal cells. Yeah.
How does it affect the prognosis?
Yes, presence of anaplasia would make it a poor prognosis tumor, because these tumors would less likely respond to chemotherapy.
What is the survival for a clear cell sarcoma in this situation? You've got a metastatic clear cell sarcoma.
Ma'am, the survival, I'm not sure regarding the exact percentages, but the survival rate is usually poor with a high relapse rate of 20 to 30%. But exact percentage, I'm not aware of.
So it's not a good thing. Yeah, it's not a good thing. But what is really important is to make sure that we are treating it appropriately and not just giving a Wilms tumor chemotherapy. So biopsy and then the appropriate treatment will at least have some survival. Okay. So we were talking about the bilateral Wilms, right? That's stage 5 Wilms. So what do you do for those children? I mean, let's assume it's not such a big tumor. It looks resectable, but it's bilateral. It's a small lesion on the other kidney, a bigger lesion in the left kidney and a smaller lesion on the right kidney.
So, ma'am, for bilateral Wilms tumors, the protocol is to give 6 weeks of VAD regimen and then reassess the tumor with cross-sectional imaging. However, if the lesion per se primarily in the first cross-sectional imaging only seems to be resectable, then in that case, we can consider nephron sparing surgery if feasible in the kidney which has a bigger lesion, if that is feasible. Otherwise, the generalized protocol is to give 6 weeks of chemotherapy of VAD, reassess after 6 weeks with cross-sectional imaging.
Primary surgery in a bilateral Wilms without any chemotherapy?
Ma'am, the standardized guidelines are to give 6 weeks of chemotherapy of VAD and then assess for
Then
CT.
why do you say to do upfront surgery in bilateral Wilms?
Ma'am, if
practiced, is that general practice?
No, ma'am, the COG protocol dictates that we have to give 6 weeks of VAD chemotherapy.
As I know, all protocols dictate that you have to give chemotherapy for bilateral Wilms. There is no role of upfront surgery in bilateral Wilms. Okay? So
Yes.
bilateral Wilms means always you have to give chemotherapy first, then reassess, because you want to do as much as, renal salvage as possible. Okay?
Yes, ma'am.
And so then what would you do? So you've done the chemotherapy, and then, one was already small to start off with. Yeah. So the right kidney was already small to start off with, and the left is shrunk about 30%. Okay.
Yes, ma'am.
And there is small lower pole left. Small lower pole, which looks, normal. Yeah. But it's involving the rest of the kidney.
Ma'am, if there has been not a if there has been somewhat response to the chemotherapy, but it is less than 50%, then in those cases we can consider giving 6 more weeks of VAD regimen and then do the repeat cross-sectional imaging and consider surgery at 12 weeks. But beyond 12 weeks, we are not going to give another trial of chemotherapy. We'll resect after 12 weeks. But at this stage, we consider VAD.
So then what would you do? What surgery would you do?
Ma'am, since it's a bilateral tumor, so in these patients, we would tend to prefer to do a nephron sparing surgery, which could be either a nephron sparing A or nephron sparing B, which would be a partial nephrectomy or an enucleation.
You would operate both sides at the same time?
No, ma'am. I would operate the side which has the bigger tumor first, and then operate the other side.
There are people who say you should do it the other way around. Okay. What is the biggest risk with bilateral Wilms tumor surgery?
Ma'am, the biggest risk would be causing injury leading to end-stage release or the
How
child.
do you do a partial nephrectomy?
For a partial nephrectomy, ma'am, in partial nephrectomy, we have to excise the tumor along with.
How will you do it? How will you do it? What is the
Ma'am,
procedure?
partial for NSSA, again, the side wherever the side, suppose for the left side I'm doing it, I'll do the left supraumbilical transverse incision and identify the lesion. In this case, the difference would be that I will resect the tumor along with the margin of the stroma
How
of
will
the.
you resect? What do you have to do before you resect?
Yes, ma'am. We can consider, we have to consider either cold ischemia or zero ischemia or a warm ischemia, so as to ensure that the kidney, the perfusion is maintained while we are doing, and there is no damage to the remnant.
So you will need
lesion.
to clamp the renal vessels, isn't it? Only then you can cut the kidney, right?
Yes.
Very rarely you will be able to do just an enucleation of something small without clamping the renal vessels. So you have to cross clamp the renal vessels. So which means the remaining part of the kidney is also having ischemic
Hypoperfusion.
damage, right? So the biggest risk with bilateral Wilms tumor excision is renal failure, which may be short-lived acute renal failure, or you may lose both kidneys completely. But even otherwise, there is a very high risk of short-term renal failure because you've got an ischemic time for the remaining kidney that you have salvaged, right? So if you do bilateral Wilms tumor in the same sitting, the risk of the patient needing dialysis or having a renal failure is very high. So what are the ways to prevent that? So if you are going to resect the tumor, having the bigger tumor first, right? So the other kidney is going to take care of it during that surgery. Okay, but now when you take out the kidney having the smaller tumor, which is the kidney that is going to handle the renal function, the small remnant which you have left behind from the larger resection. And when you're doing the larger tumor resection, there is always a real risk that you might end up with a total nephrectomy, that you might not be able to salvage even a small portion. Okay, so thinking about it in that situation, then it may be safer for you to approach the smaller tumor first. Okay,
Yes.
because whatever functioning renal tissue is there along with the bigger tumor in the other kidney, that can manage that post-operative period when the partial nephrectomy kidney is recovering. So that's what I do. I would rather go for the smaller tumor first. Then a week later, then you can go for the bigger tumor, because by then the smaller tumor would have recovered. The kidney where you've done the partial nephrectomy would have recovered. And if that kidney has recovered, then there is less risk or less strain on you. If you can do a partial nephrectomy on the second site, great. But if the tumor is too big, you cannot do a partial nephrectomy. You can safely go ahead and take out the full kidney because you've preserved part of the other kidney anyway, right? Okay. So different ways to skin the cat, but that's what I do. Okay. Dr. Mamta?
Yeah, Dr. Lakshmi.
Yeah,
One
any other questions? I think we are reaching the end of the time.
One last question.
Ah.
So can you, are you aware of some protocols or ongoing clinical trials going on to improve survival in patients with difficult Wilms tumors or difficult renal tumors? Clinical trials, like for bilateral renal tumors, for rare renal tumors where mortality is high.
Protocols, I'm not sure, but
Clinical trials. Iron trial, have you heard of it?
iron trials I know, but the exact iron number, I don't recall the protocol right now. Sorry.
You should know this. You should learn these basics of these things.
Yes.
Okay, I think you've done quite well, Soumya. Quite happy with the way you've answered a lot of these questions.
I'm impressed. I'm impressed.
Yes. Yes. So it's very good. And good presentation.
Thank you.
So,
It was an extremely enriching academic session, ma'am. Thank you for your presentation. Thank you for your time, Lakshmi ma'am and Nopal ma'am. With grateful heart, gratitude from all our coordinators. And we'll all look forward to the next session on 28th. That is by the case for all exam going students for radiology and for the upcoming exam. Thank you, everyone. Have a great night. Thank you, ma'am, for joining us and giving us your time and valuable input.
Okay, thank you.
thank you. Good night.
Good night.